Good morning, everyone. So, today we are starting our pediatrics marathon and we start with the newborn care. So, this video is for newborn for step 2 USMLE CK, and for USMLE step 2 only we'll do the important points that are relevant to the exam. So, let's start. So, we start with the APGAR score. So we know APGAR score is routinely assessed at 1 and 5 minutes and every 5 minutes thereafter for as long as the resuscitation is continued. So the full form you can remember with the name APGAR itself, or what I have remembered as R3TC, that is rate, respiration, reflex, and TC for tone and color. So there are 3 points, 0, 1 and 2 points that are given. So if heart rate is more than 100, you give 2 points. If it is it is less than 100, then 1 point. And there is no heart rate, no heartbeat, so 0 points. Respiration, 0 for none. And if it's irregular, shallow and gasping, so it is 1 point. But if the newborn is crying, it's 2 point. Color, if it is cyanosed or blue, so it's 0 points. And if the newborn is pale and have blue extremities, that is acrocyanosis, so it has 1 point. And 2 points if the newborn is pink in color. And tone is, if there is none, then it is 0 points. If there is weak tone like passive, so 1 point. And if there is active tone, then there is 2 points. Reflex irritability we can see from the facial grimace, 1 point we can give, and for active withdrawal we give 2 points. So like this we do this R3TC, all the 5 parameters at 1 minute and 5 minute. At 1 minute score, APGAR score help us to determine what happened during the labor and delivery, so we can know about the initial condition. And at 5 minutes we have the idea of the response to therapy when we are resuscitating the newborn. So normally, if an APGAR score of a newborn is 0 to 3 at more than 5 minutes compared to an infant which has normal 7 to 10 score, so that in infant with low APGAR score will have worse neurological outcome. Now we can go to another newborn important topic, that is newborn screening for various diseases and enzyme deficiencies. So we now normally have tandem mass spectrometer in all the states of United USA, and it is typically done around 24 to 48 hours of feeding prior to the baby leaving the birth hospital. With early discharge, we can perform it first postnatal visit around 3 to 5 days. And addition to that, we get the sample from heel stick blood sample, and what disorders, the examples it helps us to identify, that is phenylketonuria, tyrosinemia type 1, 21 hydroxylase deficiency, classic galactosemia, sickle cell hemoglobin, and thalassemia traits or thalassemia, congenital hypothyroidism, cystic fibrosis. So, among various newborn screening of enzyme deficiencies and various congenital infections, we can rule out two important, that is phenylketonuria and classic galactosemia. So phenylketonuria is mainly phenylalanine hydroxylase enzyme deficiency, which leads to accumulation of phenylalanine, and it accumulates into the body fluids and CNS, which leads to the intellectual disability, vomiting, growth retardation, purposeless movements, athetosis, seizures. And it is mainly associated with fair hair, fair skin, blue eyes, tooth abnormalities, microcephaly, and they normally appear normal at birth, but gradual changes can be seen in the first few months. And what is the treatment? Treatment is mainly low phenylalanine alanine diet for the life, The next one is classic galactosemia. We know we studied in biochemistry, very important. Galactose 1 phosphate uridyl transferase deficiency, which leads to accumulation of galactose 1 phosphate with injury to kidney, liver, and brain. And often it causes direct jaundice and hepatomegaly, vomiting, hypoglycemia, cataracts, seizures, poor feeding, poor weight gain, intellectual disability, and also predisposed to the E. coli sepsis and leads to developmental delays, speech disorders, learning disorders. So it may begin prenatally with transplacental galactose from mother. So treatment is not giving any lactose that reverses the growth failure and the kidney and liver abnormalities and the cataract, but not the neurodevelopmental problems that have already occurred. The next very important thing to assess is hearing loss. So in pediatric, hearing loss is more prevalent than most of the cancers or metabolic diseases like diabetes. And universal newborn hearing screening is recommended prior to discharge of the newborn. And the goal is to evaluate all hearing losses by 3 months. So how it is done mainly with a autoacoustic emission test, which is just a small earphone or microphone that is placed in the ear and sounds are played. If the hearing is normal, the echo is reflected back into the ear canal and is measured by the microphone. If hearing is not normal, then auditory brainstem response test is given, which is more accurate hearing measure through age 6 months, and sounds are presented through a small earphone measured with a head electrode and analyzed by a computer. So normal autoacoustic emission, so there is intact hearing through the cochlea, and if there is normal auditory brainstem response test, then it establishes the integrity of auditory nerve. So it is more specific. And we can see autoacoustic emission is more like for screening out. As for the cause of hearing loss, like 60% prelingual is genetic, and 70 to 80% of that is autosomal recessive, out of which half of the defects are in connexin 26, which is a gap junction protein. And some of the examples which are associated with this hearing loss, like Waardenburg syndrome and neurofibromatosis 2, both of them are autosomal dominant, and Alport syndrome, which is autosomal recessive. And rest in 1/4 cases it is non-genetic, and 1/4 it is idiopathic. Some other causes can be like cytomegalovirus, which is most common congenital cause, and there can be otitis media with effusion, which is most common in childhood. There can be bacterial meningitis, especially with the pneumococcus, which occurs early, and there can be due to trauma to the temporal bone, or some drugs like aminoglycoside and loop diuretics and cisplatin. So these were the parameters of what are causing the early hearing loss in a newborn, and how can we measure it, screen it, confirm it. Now we come to the fetal growth and maturity, which is very important to analyze. So normally intrauterine growth restriction can be of two types, can be symmetric, can be asymmetric. So symmetric usually occur due to in utero insult and affect most of the organs because it is genetic cause or chromosomal abnormality or due to teratogens or toxins while pregnant. And etiology it is etiology dependent mostly, the complications that occur, and that leads to the delivery of oxygen and nutrients to vital organ very less, and that leads to the symmetric IUGR. Now in asymmetric it is head sparing because it occurs late onset after the fetal organs have already developed, and it's mainly due to uteroplacental insufficiency secondary to any of the maternal disease like malnutrition, any cardiac, renal or anemia, and any placental disruption like autoimmune or hypertension or abruption. And main complication in asymmetric or head sparing is neurological due to asphyxia. If the amount of oxygen that is being delivered to brain is decreased. Now we can know about gestational age and size at birth. There is something called large for gestational age, something which is small for gestational age. Also, one classification according to the age is preterm and postterm. So first, preterm is premature, live-born infant which are delivered prior to 37 weeks as measured from the first day of the last menstrual period, and usually low birth weight is less than 2.5 kg due to prematurity or IUGR. The post term is infant born after 42 weeks gestation from last menstrual period. When the delivery is delayed more than 3 weeks past term, significantly increase in mortality occurs. So we have to be very careful about that while managing the post term pregnancy. And characteristics are increased birth weight, there will be less lanugo, and there will be decreased or absent vernix, there will be desquamation and pale loose skin, there will be abundant hair, long nails. If placenta is insufficient, there may be meconium staining. Now there is a term called large for gestational age, and in this the birth weight normally is more than 4.5 kg, and predisposing factors are mainly maternal, and higher incidence of birth injuries and congenital anomaly occur because the fetus head is large, okay, or their size is large, and while passing through the female genital tract due to bony injuries, due to the passage in the tract cause bone injuries. Now we come to the endocrine disorders, which the most important being infant of a diabetic mother. Since maternal hyperglycemia occurs, it can be type 1, type 2. Mainly it leads to fetal hyperinsulinemia. So insulin is the major fetal growth hormone which increases the size of all organ except the brain. So major metabolic effect is at birth with sudden placental separation. And infants may be large for gestational age and plethoric, and other metabolic findings that can occur with it is hypocalcemia, hypomagnesemia. It is mainly due to delayed action of parathyroid hormone. What are the common findings that we can see in infants of diabetic mother are? We can see macrosomia, which leads to birth trauma, transient tachypnea, respiratory distress syndrome, cardiac failure, hypoglycemia. We can see cardiomegaly but with asymmetric septal hypertrophy, and it is due to the hypertrophy is due to the insulin effect, and it is reversible. And then the polycythemia can occur with hyperviscosity, and that can lead to hyperbilirubinemia and jaundice. Renal vein thrombosis can occur, presenting as flank mass, hematuria, and it may be due to polycythemia. And increased incidence of congenital anomalies occur, like in heart, especially VSD, ASD, transposition of great vessels. Small left colon syndrome is very important in it, which is transient delay in the development of left colon side, and it present with the abdominal distension. And one more important is caudal regression syndrome, which is spectrum of structural neurological defects of caudal region of spinal cord, which may result in neurological impairment. And the prognosis in the infant of diabetic mother are more predisposed, is not very good. They are more predisposed to diabetes, and large for gestational age infants having more risk for childhood obesity. And treatment for this is careful monitoring and glucose control during the pregnancy, and close monitoring of infant after the delivery, and early frequent feeds, oral or nasogastric if hypoglycemia continues, followed by the IV dextrose if euglycemia has not been achieved. So this was infant of diabetic mother, very important endocrine disorder that we can see with the newborn and how can we manage it. Now if we go to the lungs or respiratory disorders that can occur with the newborn. So respiratory distress, newborn can present with the respiratory distress, and the cause can be respiratory as well as can be non-respiratory. So in respiratory, mainly respiratory distress syndrome, transient tachypnea of newborn, meconium aspiration syndrome. In non-respiratory, it can be due to heart, like cyanotic congenital heart disease. It can be due to anemia, polycythemia. So we go with the respiratory distress syndrome. So this is mainly deficiency of mature surfactant, that is surfactant matures over the gestation with the addition of phosphatidyl groups, and so the incidence of surfactant deficiency diminishes towards the term, because it has already been matured and formed and actively secreted with term. And the inability to maintain the alveolar volume at the end expiration leads to decreased functional residual capacity and atelectasis. So this is the pathology behind the RDS due to deficiency of the mature surfactant. It leads to the decreased FRC and atelectasis. And primary initial hallmark is hypoxemia, and further hypercarbia or respiratory acidosis can occur. Now diagnosis, how we'll diagnose it? With chest radiograph. And what we'll find on the chest radiograph? We'll find the ground glass appearance, low lung volume, and air bronchograms. What is the most accurate test for it? So that is lecithin to sphingomyelin ratio, and it is done on the amniotic fluid prior to birth. And the best initial treatment is oxygen, and most effective is intubation and exogenous surfactant administration. And how can we prevent it? By preventing the premature delivery with tocolytics, and also if there is premature delivery, giving antenatal beta-methasone for maturation of lungs. Now transient tachypnea of newborn is that it occurs in term babies. It is slow absorption of fetal lung fluid, and that leads to decreased pulmonary compliance and tidal volume with increased dead space. So tachypnea occurs after birth, and it requires minimal oxygen, and it occurs in term infants who have undergone cesarean or rapid second stage of labor. And on X-ray we'll see, chest X-ray we'll see air trapped and fluid in the fissure and perihilar streaking very distinctively. And rapid improvement can be achieved by monitoring and pulse oximetry. And now we come with the meconium aspiration, which is meconium is passed as a result of hypoxia and fetal distress, and it may be aspirated in utero or with the first postnatal breath. So that can this meconium can go and obstruct the airway and cause pneumonitis, and it can lead to pulmonary hypertension. So chest X-ray, if we do, we'll see patchy infiltrates and increased antero-posterior diameter, and diaphragm will be flattened. And other complication like pneumothorax and pneumomediastinum can occur. So prevention is mainly endotracheal intubation and airway suction of the depressed infants with thick meconium. And treatment is positive pressure ventilation, and if other NICU therapy is required, we can go for that. And diaphragmatic hernia is failure of diaphragm to close. So abdominal contents enter into the chest, causing pulmonary hypoplasia, born with respiratory distress and scaphoid abdomen. So bowel sounds may be heard in the chest. So if we can diagnose it with ultrasound, even in prenatal ultrasound, and in postnatal X-ray we can see bowel reveal the bowel in the chest. And best initial treatment is immediately intubate in the delivery room, followed by the surgical correction when the newborn is stable, usually some days. So this was our respiratory disorders that can occur in the newborn. Now we can go further into other organ system like gastrointestinal and hepatobiliary disorder. So what are the disorders that occur with a newborn or can occur are commonly seen like umbilical hernia, in which there is failure of umbilical ring closure due to weakness of abdominal muscles. Most are small and resolve in 1 to 2 years without any treatment. And if it is large or there are symptoms like strangulation and incarceration, or it is persisting after age 4, so we can go for surgery. So in these cases we'll go for surgery. Otherwise it resolves in 1 to 2 years if no, if it is small and doesn't require any treatment. Now, omphalocele and gastroschisis is very important. We always get confused which one is which one is covered by the membrane. So I have a small trick to remember it. So there is omphalocele. So always remember O. So O is complete circle. It's like covering something. So O is the one who has cover is omphalocele. The O is the cover. Okay. So I know it's a little bit silly, but it's okay. It helps me differentiate. So whatever works, and you can try it too. So what is omphalocele is like failure of intestines to return to abdominal cavity with gut through umbilicus at 11 weeks gestation. It is covered in sac and opens through the umbilicus. It can be associated with some trisomies too, and if there is large defect it needs reduction like with surgical silo. And now we can come to gastroschisis. What is it? It is also a defect in abdominal wall but lateral to umbilicus. These are the differentiating features you can see from the omphalocele. That is through umbilicus. Gastroschisis is lateral to umbilicus, and any part of GI may protrude, and it is not covered by a sac. That is the most important differentiating factor. And major problems that can occur with intestines are like atresia, stenosis, ischemia, shortcut, and we can go for surgery if there is any complication and if there is large lesions that require staged reduction. Now we can come to other very important thing that newborns go through, mainly premature newborns, that is necrotizing enterocolitis. Transmural intestinal necrosis occurs, and we know the greatest factor is prematurity because it leads to immature gut barrier and with enteral feeds and possible microorganisms that cause the infection. And symptoms are usually related to the induction of feeds, and it will present as bloody stools, or there is difficulty breathing, lethargy, the abdomen is distended, and if the perforation occurs, that is the surgical emergency. And like pneumatosis intestinalis can be seen, that is the air in the bowel wall can be seen if we do an x-ray abdomen, plain abdominal x-ray. And treatment, how can we treat it? Like cessation of feeds we can do, we can decompress the gut, we can give the antibiotics, systemic antibiotics for the infection, we can give supportive care, and if there is any necrotic bowel we can surgically resect it. So we have to go for surgical consult in it. Now imperforate anus is failure to pass stool after birth, so no anal opening is visible, and treatment is mainly of course the surgical correction you have to do, and it is part of the vectoral mnemonic that we hear association with the genetics. And now other thing in hepatobiliary that we see commonly is jaundice. So it is mainly the increased production of bilirubin from breakdown of fetal RBCs, and due to immaturity of hepatic conjugation of bilirubin and elimination in the first week of life, so physiological jaundice appear. And physiological jaundice is mainly on the second to third day of life, disappear by the fifth day in term, and on 14th day or 2 weeks in preterm. And peak bilirubin is not more than 13 milligram per deciliter in terms, and the rate of rise is also not is always less than 5 milligram per deciliter per day. In contrary, the pathological jaundice will appear in the first 24 hours of life, and bilirubin will go more than 13 milligram per deciliter, and peak bilirubin is unlimited, and rate of bilirubin rise per day is more. And what is the main thing that we are worried about is kernicterus. So rapidly increasing unconjugated or indirect reacting bilirubin can cross the blood-brain barrier and lead to unconjugated bilirubin in the basal ganglia and brainstem nuclei. That is called kernicterus, which present as hypotonia, seizures, opisthotonus, delayed motor skills, and chorioathetosis and sensory neural hearing loss. Now, what are the causes of hyperbilirubinemia from the bilirubin metabolism prospects? So, first of all, like in RBC metabolism, there is increased RBCs. Like in physiological jaundice, hematocrit is more in newborn 42-65, and in polycythemia, hematocrit is more than 65, and it is due to either chronic hypoxia, IUGR, or infant of diabetic mother, or insulin effects in and trisomies. So extra RBCs are entering the circulation due to like delayed cord clamping or twin to twin transfusion. So what can we do in this polycythemia? We can do partial exchange transfusion with normal saline. Now other thing that can occur in jaundice can lead to jaundice is increased hemolysis, and hemolysis can be both immune mediated and non-immune mediated. So immune mediated is highly conjugated bilirubin, and it will show with increased reticular sound and positive direct Coombs test. So where does this occur? So in Rh negative mother and with Rh positive baby, which is the classic hemolytic disease of newborn. It can be ABO incompatibility where mother is type O and baby is type A or B, and it is the most common reason for hemolysis in newborn. And there can be some minor blood groups involved in compatibility, like Kell is very antigenic. Now, what are the non-immune causes where Coombs is negative? So, what will it appear for non-immune mediated? Like it will appear characteristic, like smear will show RBC membrane defects. Like in spherocytosis, it will be so you can see the spherical shape of RBCs, elliptocytosis. And the one smear where the RBCs look normal but still have non-immune mediated hemolysis, that is enzyme defects like G6PD or pyruvate kinase deficiency. The cause of hemolysis can be extravascular also, like due to excessive bruising or cephalhematoma. And normally bilirubin is bound to albumin and carried in the blood, and bilirubin may be uncoupled from albumin in the bloodstream to yield free bilirubin. Example, neonatal sepsis, some drugs like ceftriaxone, hypoxia, acidosis, and bilirubin is transported to hepatocytes. Within the hepatocyte is the conversion of unconjugated fat soluble bilirubin to the conjugated water soluble bilirubin, which is also called in lab directly acting or direct bilirubin, by the action of hepatic glucouronyl transferase enzyme. So this enzyme activity can be decreased normally in the first week of life, or there is any liver disease, some infections like TORCH or metabolic diseases. And no activity of this enzyme is mainly specific in Crigler-Najjar syndrome type 1. Type 2 has some activity preserved around. So transport through this intrahepatic biliary system to the porta hepatis for excretion into duodenum. So abnormalities of transport can occur, and excretion they all cause conjugated hyperbilirubinemia because it has already been conjugated. Now it's just passing through its way to its target site. So any blockage to in that area of its passage will lead to the conjugate hyperbilirubinemia, and mainly the direct hyperbilirubinemia more than 2 mg per dl. And it can also occur, the conjugate hyperbilirubinemia, if there is biliary atresia, that is progressive obliterative cholangiopathy, and obstruction is there at the birth due to fibrosis, and there is atresia of extrahepatic ducts, and we can see there is inflammation and fibrosis of intrahepatic system, which ultimately leads to cirrhosis because bilirubin is also obstructed. And in these cases, it usually present within 2 weeks of life with jaundice, that is conjugated hyperbilirubinemia, and poor feeding, vomiting, lethargy, and hepatosplenomegaly, acolic stools, and dark urine. The parents may tell you like the newborn is passing acolic stools and dark urine. And best initial test for this is ultrasound, and we can see the ductal anatomy, if there is any gallbladder or not. And the most accurate is percutaneous liver biopsy, which is pathognomic. And initially we can treat it with which is palliative, is hepatic portojejinostomy, that is also called Kasai procedure, in which we do hepatic portojejinostomy. And best long term treatment has to be liver transplant. So now in intestinal transport and excretion, most of the bilirubin is eliminated in the stool, with final products synthesized with the help of colonic bacteria, and bilirubin is eliminated in urine. Some is reprocessed in the liver due to enterohepatic circulation, along with the bile acids. And intestinal beta glucuronidase hydrolyzes this glucuronide bilirubin bond to yield some unconjugated bilirubin, which is then absorbed into the portal circulation and transported back to liver to be acted upon by the hepatic glucuronyl transferase enzyme and conjugated again and goes again through the same cycle. So there are some cases where this enterohepatic circulation is increased. It can be intestinal obstruction, it can be decreased colonic bacteria, like in first week of life it's immature gut, and prolonged use of antibiotics can decrease the colonic bacteria, or severe diarrhea. Breast feeding jaundice is due to decreased intestinal peristalsis. And breast milk jaundice, which is excessive concentration of glucuronidase in breast milk, leads to increased enterohepatic circulation and jaundice. So that is the difference. They normally ask what is the difference between breastfeeding jaundice and breast milk jaundice. So breastfeeding jaundice is due to decreased breastfeeding. We are not giving it timely, and decreased intestinal peristalsis. So treatment is mainly timed breastfeeding and frequent. And breast milk jaundice is due to an enzyme which is in the breast milk, that is glucuronidase. And we already know intestinal beta glucuronidase hydrolyzes the bilirubin and glucuronide bond, and it leads to increased unconjugated bilirubin ready for the enterohepatic absorption, or so back into the liver. So that what causes the jaundice in breast milk jaundice. So treatment of hyperbilirubinemia, what you can do, there are main two options: phototherapy and double volume exchange transfusion. So phototherapy complications mainly include like loose stools, erythematous macular rash, overheating or dehydration. And double volume exchange transfusion is done mainly if bilirubin continues to rise despite intensive phototherapy, or if there is a concern that kernicterus can occur. So then we go for DVT. So also I wanted to go again in the topic of breastfeeding jaundice and breast milk jaundice differences. So breastfeeding jaundice mainly by lack of calories and dehydrated infants because not given breastfeeding timely, and so the peristalsis decreases, and the intestinal enzyme, that is glucuronidase, get more time to hydrolyze the bilirubin and glucuronide bonds and increase the enterohepatic circulation more, and which leads to jaundice. So we can just rehydrate the baby and better breastfeeding. And breast milk jaundice mainly occur in 2 weeks of life, and due to increased beta glucuronidase in breast milk, and since the activity of this enzyme decreases over the first 2 to 3 months of life, so it itself resolves mostly. And if the bilirubin may rise again, and if you think it's needed, you can give phototherapy. So now we come to the last part of newborn that's very important, that is neonatal infections or sepsis. So what are the main causes? Of course, sepsis first risk factors will be prematurity, chorioamnionitis, intrapartum fever, prolonged rupture of membrane, early onset and can be late onset. Early onset occurs in the first week due to chorioamnionitis, and the organisms included, I remember it as Bell's, BELA, that is group B streptococci, E for E. coli, and L for Listeria monocytogenes. And late onset occurs in second week and or the end of the neonatal period, and mainly iatrogenic infections. And most common in this late onset neonatal sepsis is Coagulase negative Staph aureus, and that is epidermidis. And diagnosis can be with sepsis workup, CBC, and differential in platelets, blood culture, urine analysis, chest x-ray, lumbar puncture, only for neonates with severe signs of lethargy, hypotonia, poor perfusion, hypothermia, apnea, or neurological findings which are abnormal. And treatment is mainly, if there is no evidence of meningitis, we go for ampicillin and aminoglycoside until 48 to 72 hour cultures are negative. And if meningitis or diagnosis of meningitis is possible, and uh, it's important to give ampicillin and third generation cephalosporins. So now last important is torch infection that we'll hear about a lot, that is toxoplasmosis. Of O is for others like syphilis, varicella, HIV, and parvovirus B19. R for rubella, C for CMV, H for herpes. So toxoplasmosis, we know it is a maternal infection worldwide that occurs with eating raw meat and undercooked meat mainly, and the raw meat contains the tissue cysts that we ingest with food and water, and the oocysts that have been excreted by infected cats, like due to fecal contamination, is the most common form of transmission in the United States. And we advise women not to change or clean cat litter while she's pregnant because she can catch the infection. So what can we see, or what are the, why is it so important? Because it leads to jaundice, hepatosplenomegaly, thrombocytopenia, anemia, microcephaly, chorioretinitis, hydrocephalus, intracranial calcification, seizures. I remember it with the mnemonic CHD, C for chorioretinitis, H for hydrocephalus, D for diffuse intracranial calcification. You can also use it. And what are the outcomes? The newborn can be visually impaired, have seizure disorder, or can suffer from the psychomotor retardation. So we treat the mothers with spiramycin during the pregnancy, and other drugs use pyrimethamine, sulfadiazine and leucovorin for the infants. So now congenital rubella that we hear a lot when we study infectious disease is classical finding when maternal infection occur in the first 8-week gestation. So I have remembered its mnemonic also as CHD, and that is cataract and hepatosplenomegaly, and for D I remember like PDA, or you can say also it leads to hearing loss, SNHL or deafness. So other things that are come as important findings are blueberry muffin spot, and we can see cataracts already discussed. But in blood we can see thrombocytopenia, hepatosplenomegaly we can see, and mainly the same things. It can lead to either the hearing loss, microcephaly, mental and motor retardation, and persistent growth retardation. So other important new infection is cytomegalovirus infection, and it can be primary infection or reactivation of the infection. So finding can be hepatosplenomegaly, periventricular calcification, IUGR, chorioretinitis, microcephaly, thrombocytopenia, hemolytic anemia mainly, and herpes simplex, which appear as correctoconjunctivitis in skin 5 to 14 days, in brain 3 to 4 weeks, and disseminated in 5 to 7 days. Best diagnosed by the PCR of any body fluid. Best treatment is IV acyclovir, and prevention with this is mainly elective cesarean when there is active disease or visible lesion that are identified, and treatment is mainly acyclovir. Now congenital syphilis is also very important. So it can occur during second half of the gestation, and it can be present with early findings, that is from birth to 2 years, and can have late findings from 2 years of age, after 2 years of age. So from in the first 2 years of life, it is snuffles, maculopapular rash on palm and soles, which desquamate, jaundice, periostitis, all the itis like osteochondritis, chorioretinitis, and later it can present as Hutchinson teeth, Clutton joint, Sebacean, saddle nose, osteochondritis, regades, that is thickening and fissure around the corner of the mouth. So how we'll diagnose it? It's mainly in the scraping from any lesion or fluid, serological test. So if an infant has positive VDRL plus the signs, so we perform like serial determination, increasing titer in the infection, and most helpful and specific test is IgM, FTA ABS, which is immunoglobulin, fluorescent treponemial antibody absorption, and treatment mainly for congenital syphilis is penicillin. Now last not the least is varicella, which can be neonatal and congenital. So delivery in neonatal occurs when the delivery occurs less than 1 week before or after the infection, and we usually give varicella zoster immunoglobulin. If mother develops varicella 5 days before, 2 days after the delivery. And in congenital, it is associated with limb malformations, scars, microcephaly, cataracts, chorioretinitis, cortical atrophy, and mainly it occurs in the first and second trimester in congenital who get the infection. So these were the infection: the congenital syphilis, varicella, herpes, CMV, rubella, toxoplasmosis, the torch group, and the neonatal sepsis. So they all have some specific findings, some specific outcomes, and how can we diagnose it and how can we treat it. So this was the newborn, a very short description of various metabolic, infectious, and whereas newborn screening and enzyme deficiency diagnosis that can be done for a newborn. So in the next video we're going to learn more about the genetics, immunization, development, growth and nutrition. So let's continue in the next video. Thank you.